Hello, my name is Patty Thorpe, and it's my pleasure to participate in the digital education series that Dr. Walker has organized, and his staff is supporting all of us to contribute to this effort of teaching by virtual imaging and contact with you. So I'm giving a talk today about whether or not you should treat people for great saphenous vein insufficiency and varicosities before you question whether or not they have deep vein thrombosis or not, or should you do it another way. And so we're going to explore that concept. These are my disclosures. I've worked with these companies for a number of years. And this is our first image. And this is the first image because this is a lady that I'll never forget. This is a lady whose right leg was her main problem when she came to see me. You can see it's swollen, hyperpigmentation, discolored. She's had an ulcer here. So she's at this point, I think, can't say if it's a C5 or 6, but she had a lot of pain. She was also addicted to opioids. Nicest lady, but her leg got this way after a physician did vein stripping in her right leg. And he never looked to see whether or not she had any evidence of deep vein thrombosis, nor did he ask her if she'd ever had deep vein thrombosis. And it turns out that in her first pregnancy, which was 25, 30 years ago, before this happened, she did in fact have a blood clot associated with the pregnancy. So he didn't ask, she didn't tell him, he didn't look, and it was within a year of doing her vein stripping on the right side to get rid of some varicose veins that her leg just went from looking pretty much like the left side to this. Well, so when you do an ablation, and we do ablations at our lab too, I say always, what could possibly go wrong if you do an ablation and there is something that you haven't figured out, like iliac compression, or post-thrombotic obstruction, or chronic iliac DVT in the common iliac area, or even chronic femoral DVT. So each of these scenarios has different things, but most of the deep vein thrombosis that's chronic and happened years ago is somewhat obscure, and most people, if they've accommodated to it, aren't too symptomatic. So it's easy to miss unless you're looking for it. Well, how do you find out if they have any underlying deep vein thrombosis? Well, first of all, you ask them with a history if they've ever known that they've had clot before. And you do an ultrasound. Your ultrasound tech should be looking at the deep venous system to make sure that there's no acute, subacute, or chronic thrombus. Now, we can deal with chronic thrombus if the veins are open and have been recanalized. And we know that by taking out the great saphenous vein, you can redirect flow into the deep system, and many people are improved. But there has to be a balance. There has to be enough flow in the deep system to not jeopardize that patient by taking away their superficial system. I think that CTA is now a very good way at looking at the bifurcation area to see if there's a compression of the iliac vein. And we recently published in the Journal of Vascular Surgery an article about CT venography compared to duplex imaging to identify iliac compression. So that was the May issue of the Journal of Vascular Surgery, Venous Lymphatic. So the other thing about understanding if there's any venous disease is to look at the patient's legs and see if they have dependent discoloration. That's a giveaway. Or swelling, maybe more on the left than the right, It can be both, but left is pretty common. So you really have to know the difference between arterial and venous ulcers and their pattern of where they appear and what they look like. And surprisingly enough, a lot of people who work with vascular procedures, particularly for saphenous vein ablations, are not familiar with the manifestations of stasis ulcers from deep venous disease and the difference between that and arterial disease. So we know that you should get that in your training, but I just want to point that out, that it's important to have these skills. Now, this is a picture of a woman who has a nice pedicure, and also more findings on the left and the right. You see these hyperpigmentation areas, and actually this is matting from sclerotherapy. And you can see that her left ankle has lost some of the contour that is still present on the right. So there's a little bit of fluid collection, a little bit of fullness right in this area. And it turns out that she has had multiple episodes of sclerotherapy. And no one ever thought to think whether or not she had iliac compression or deep venous component to the fact that her left leg didn't feel good. And she kept getting a lot of superficial work done because she was complaining about her left leg. Now, it didn't help that her husband was a vascular surgeon and he readily could do most of that for her. But the fact is that the deep venous system just stayed below the radar until I identified that she had an iliac compression as well. How do you know if somebody has an iliac compression? Well, you know, when I do ablations, I always am looking at the duplex ultrasounds for the patients we're doing, and I always look at the external iliac vein to see the waveform. And a very significant compression in the common iliac or proximal external will give you a non-phasic waveform in your external iliac. So this is a pretty much of a flat waveform. There's still augmentation, but it's not a very there's not very much of a waveform because there's essentially a proximal obstruction. And it'll be something like this in most people where the artery comes across and compresses that iliac vein and results in a lack of transmission of the waveform from the cardiac diastolic systolic motion. So that's why you get a flat waveform in this area. And actually, it's not too convenient to go that high. With most patients, you have to go use a curvilinear probe. So if you're just checking in your lab to make sure that you don't have a major compression, then you would check right above the inguinal ligament and see if there's any evidence of a non-phasic flow. If you find non-phasic flow, then you go to a more formal duplex ultrasound with a curvilinear probe in the upper pelvis area and look at the velocities. Here are nearly 64 centimeters per second. And that's very high because normally they're in 30, 35. So this is an indication that the vessel is narrow, right below the artery, a compression for sure, and that you have your telltale signs of the high velocities in the common iliac and your flat line waveform below. Then your tech will give you some kind of diagram and information about elevated velocities in the common iliac, low velocities in the external iliac, and non-phasic flow or flat line. It still augments, but it's a flat waveform. That's a classic picture of someone who has all the elements of a May-Thurner compression. Whether or not they have a May-Thurner syndrome is a different story. May-Thurner syndrome has to do with the symptoms of heaviness, fatigue, achiness, itching, pelvic discomfort, low back pain. So the syndrome is different than the compression. The compression is present in about a third of human beings. Some of it's severe, some of it's not so severe. The syndrome is found more often in females because they have more risk factors combined with this mechanical risk factor of the iliac compression. Those other risk factors include hormones, either birth control pills or postmenopausal hormones, pregnancy itself. Any steroids are hypercoagulable, and so as men have been taking more and more testosterone injections, we've seen more of the May-Thurner syndrome appear in men as well. Here's another picture of your almost non-phasic flow here, low velocity. It's a little bit phasic, but not much. And this is a patient who does have a May-Thurner. Now, again, I want to teach you this position of looking at the ankles in your clinic. Have the patient on the table, bring their knees up, put their ankles together, and you take an image of just their feet and their ankles. That's the very best way to see if there's enlargement on the left side. This patient obviously has left leg edema, and a lot of patients come to me with numbness and pain in this area from having had a low access for a sheath for ablation. And when some patients have this plus dorsal, the dorsum of their foot edematous and their toes edematous only on one foot, then we know that there has been damage to the lymphatics in this area associated with the ablation or some sclerotherapy, and they have lymphedema because of damage to lymphatics in this area. Here's a patient who demonstrates dependent discoloration, which is pathognomonic for proximal obstruction. Here's a patient who has had multiple saphenous vein procedures. You can see the discoloration from the procedure. This lady, does she have deep vein disease as well as obvious superficial vein disease? Sometimes when the superficial veins are so bad and they're up in the vulvar area, we know that they have possibly some iliac compression promoting pelvic congestion as well. But this has to be all explored with a very thorough ultrasound, sometimes CTA, and if necessary, a venogram with IVUS. It's fine to do the ablation procedures and all of the phlebectomy, but it has to be done in the right order in order to protect the patient from getting worse. This is also a nice young lady, and I point out how subtle it can be to see dependent discoloration in a leg that has a May-Thurner above. This is her normal leg. This is a little bit of dependent discoloration without a lot of ankle edema. This is another patient. I think it's the same patient that I showed you before because I can see by the toe polish, but this is with the matting and the widening here of her left ankle. Now I want to show you that she did, in fact, on venography, have a serious compression. Now, this is an iliac compression, which is almost like a half May-Thurner, but the width, the AP diameter is very compromised. And although flow goes through here at a rate that you would say, so what's the big deal? It is a lesion in her deep venous system, and when it was corrected with a stent, she never again had tibial thrombosis, and her leg felt much better and less heavy, and she was very pleased with the outcome, the clinical results. So this is a significant lesion, even though it's not a total occlusion. This is another woman that I wanted to share with you. She came to me and she just recently said in clinic last week, how come I got 9 procedures on my left leg and my right leg together before anyone ever figured out that I had chronic iliac thrombosis? So she developed, after her last procedure on her left leg about a year ago, she developed an ulcer. And that ulcer stayed open until she got an iliac stent placed to decrease the amount of venous pressure in that left leg. This is another patient who presented in the ER with ulceration on the lateral malleolus. And then there was also an ulcer here on this patient who was a massage therapist, a thin lady. She stood all the time. She had a saphenous vein ablation, and then she developed an ulcer. She had some sclerotherapy here too, which contributed to this, demise of the skin here. So it was an open ulcer. And then we discovered that she did, in fact, have an iliac compression. You can see the vein is almost like twisted. It comes to a point right here and is flattened right there. And here is her IVUS showing that it was quite narrow, 5 millimeter AP diameter by 24. Here's her stent in position. This was done a number of years ago. She lives in Yuma and she's doing well. We follow her on an annual basis, but she, not only did her leg feel better, this is after the stent was placed, but her ulcer changed significantly. It dried up quite quickly. On the 5th of March, it was looking like this with discoloration and that big. Then by the 19th of March, which is just a little over 2 weeks, she is almost closed, and she did in fact close that ulcer. Now I'm going to end with this one patient who is also a combination of both superficial and deep disease. It's not really a mystery whether or not he has the combination of these diseases like some of these other people, but the question is what to do to help him. He had all these changes from his superficial disease, and he periodically is dry skin. He'd open an ulcer, and he worked. He's a baseball umpire, so his passion is doing that, and he has to be on his feet a lot. So his complaints are this burning sensation and swelling. Can't stand the feeling of compression on his leg. The great saphenous vein, after it was ablated, has since reopened, and he ends up having reflux that we can see in both the above the knee, below the knee areas of the saphenous vein. So as I said, he's an umpire. He came before he had any ablation done by one of my colleagues in cardiology. He had bilateral foot neuropathy, which was bothersome, but not the worst. But in September of 2017, he got a radiofrequency ablation. He ended up developing thrombophlebitis and thrombosis of both the popliteal and femoral veins. And he got a thrombophlebitis and thrombosis after he had his ablation. So that's how I got involved to help do the catheter-directed TPA. The right distal external iliac stenosis was identified, and a significant common femoral reflux had developed over years because the patient just stood all the time and crouched down. And he was really loath to have anyone put a stent in him because he loves being an umpire, and he thought because he bends over for his occupation that a stent wouldn't be a good idea. I finally convinced him the stent would be a better idea than the way he was, and he's done fine with the stent. But he ends up with this residual discomfort, burning, redness. It gets, sometimes it's worse, sometimes it's better. And here is the ultrasound showing how much reflux he has through a recanalized saphenous vein. So this is a predicament, and I present this to you because I think it's a puzzle. And I took this case to the vein experts meeting in New Jersey last year to get everyone's opinion to see what they thought should be done. So you can ask yourself if you, at this point, would do a vein stripping. Probably not. Valve reconstruction. Probably not. His common femoral valve reflexes, but now he has a stent there too. He does probably have this regional pain syndrome, which waxes and wanes. Sometimes it's bad. But everyone came up with the idea of probably retreating the saphenous vein. Would you retreat with radiofrequency, laser, or foam? And I believe the consensus of those who had experience in this area suggested that it would be okay to do either with foam or with radiofrequency, and to be sure to look to see if there were any perforators involved. So I think that's an interesting case of the combination of superficial vein disease, a deep vein. It's not always a mystery, but remember what I said about keeping that in mind. And when you go to do an ablation for the right reasons, you have to ask yourself, what could possibly go wrong here? If I'm missing some deep venous disease, I better make sure they don't have a history, or that I'm not missing some signs and symptoms of occult iliac compression. Well, thank you very much for your attention. I hope that this was helpful. And again, thank you to Dr. Walker and his staff for including me in this digital education series. Thank you.